WCLN 1170 Radio and Star Vision Cable Channel 16 are pleased to present We Should Know, hosted by J.W. Simmons, an upbeat, informative look at people, places, and issues facing our community. This education-based analysis of issues will remain positive and informative as we consider closely what we should know.
Ladies and gentlemen, welcome back. The name of the show is We Should Know. We're on the air on WCLN 1170 Radio, Star Vision TV, Star Television, Channel 16, Tuesday, Wednesday, Thursday, a replay at 7 p.m. I want to thank Nicole for a wonderful introduction she does each and every week for the show. Had a lot of comments on our previous programs that have been on the air for the past couple of weeks. A lot of interesting comments coming from you, and we appreciate that. We also appreciate you contacting us on weshouldknowedu@gmail.com. weshouldknowedu@gmail.com. Today we're talking about things in medicine, things that's important to you, and particularly our own hometown orthopedic surgeon and sports medicine doctor, Dr. Alex Huff. Dr. Huff, thank you for coming back, taking time to be with us. I know you have one heck of a schedule, because I usually, to try to schedule you to get you on, I have to contact your folks and work it in, because you're in and out of surgeries, you're constantly moving forward. But just to kind of refresh folks a little bit about who Dr. Huff is, in case there might be one or two people that don't know. Let's talk about you and your background a little bit. You're board certified, you've done a lot of stuff in medicine. I came here, has it been 17, 18 years since you've been in Clinton?
Well, first of all, let me tell you, thanks for inviting me.
Absolutely.
But my wife and I, and my two daughters at the time, my expecting wife, we moved here in 1998, in the spring of 1998. So it's been a little more than 15 years.
Wow. Time goes by fast. Now, you you spent some time in Clearwater, Florida. Tell us about that experience there.
Yes, well, that was the tail end of my training, where I did what's termed a fellowship, and that's a one-year period of intensive training. That's usually completed after your residency. I did a 5-year residency in orthopedic surgery prior to that in Orlando, Florida. But the year in Clearwater was intensive training of knee replacement, arthroscopy, sports medicine, and basically joint replacement, where we did over 1,500 joint replacements that year, and then several hundred anterior cruciate ligament reconstructions, things like that. So you get just intensive training. My mentor said you go from flying a plane to flying a jet in that 1 year. So it was a good year.
And graduated from East Carolina University, from the School of Medicine there, with honors. And I'm told that East Carolina graduates more doctors than any one of our medical schools in North Carolina. I didn't realize that.
Well, they graduate more doctors that go into primary care, more of the primary care specialties. There's 4 medical schools with MD programs, and now a new DO program starting up at Campbell. But East Carolina traditionally has had more physicians that go into primary care, but they also have more physicians that stay within our state, which is important. As a state-funded school, it's nice that their graduates look to practice in North Carolina.
And I think it's important when we look at that too, to look at doctors, as you said, and doctors particularly stay in North Carolina, and even more particularly for this area. And I'd say all the surrounding counties. We've reached about 8 or 10 counties, so all of these counties that listen to us or watch us on TV, you know, it's important for them to understand these are kind of rural areas, and it's kind of tough to get docs to want to locate in rural areas for many reasons. Some of them tell me their spouses like a little urban setting better, so it's tough for us. And this is a great advantage for us as well.
It really is difficult to get doctors, both primary care and specialists, to stay in the area. Some data from the American Academy of Orthopedic Surgeons recently showed that only 2% of board-certified orthopedic surgeons practice in communities under 100,000 people. And so we're fortunate to have any specialists here in Sampson County. And I think some of the reasons that people are a little hesitant to relocate here are certainly not the quality of life, because it's a great place to live, but people are worried about the economics and worried about having a patient population large enough to support their practice, and then obviously the spousal issues as well too. Most specialists are going to feel comfortable around a larger medical center in a larger metropolitan area. But fortunately, by luck, and I'd like to say by skill also, we've been able to make it here in Sampson County and have developed a thriving practice.
Well, and I think the numbers kind of reflect that. Over 8,000 surgeries right here at Sampson Regional Medical Center.
Right.
And that's a huge number any way you look at it, of actually helping people to continue their life in a pain-free, hopefully a better environment than when they came in, and I think your numbers reflect that.
Absolutely. We've been very fortunate to be able to do that, the volume of cases that we do here, and I've been able to hold on to the true generalist mentality as well as a general orthopedic surgeon, operating on upper and lower extremities, both the young and the old, major surgeries and minor surgeries, and so I've been able to maintain my skills in all those areas, and although my focus of training has been the knee, I've been able to maintain a thriving practice that covers the entire spectrum of orthopedic surgery, which is fulfilling.
You know, and Dr. Huff, I know you're the kind of person that likes to talk directly to your patients, and you've got excellent skills when it comes to communicating with people. In fact, I see you out in the public a lot, and everybody will see you, and they might see you in a grocery store, and they just pull you over to the side. In fact, just before we aired today, some folks here were saying, well, you remember me from so-and-so. So I won't ask you this question. Just talking to patients and communicating with patients, is that something that's taught in medical school, or do you just develop that over time, or do you get that from hanging around people like Mayor Starling, or what?
Well, you know, that's a very good question, and certainly all of your life experiences play into your ability to communicate with people. You know, you are taught to a small extent how to take histories and how to listen to people, and listening, I think, is more important than talking. But in talking with people, what I do primarily is try to educate them and try to, from their point of view. I've been a patient too, and it's tough. I'm telling you, I've got a great respect for patients because it's difficult. But try to educate my patients about particular procedures, about their treatment options, and try to bring it down or up to a level that they understand and that they most appreciate. And whether you're talking with younger people or older people or highly educated people or not so educated people, I think it's important to be able to deliver the information to them in a way that they can understand and help arrive at good decisions.
Now, it's one of the things I think is interesting with your practice too, you've got an added appendage there that's called the sports medicine piece to that. Only about 2,500 doctors in the entire United States have that part of a orthopedic surgeon title that they can say sports medicine is part of that. It's a huge plus, I think, particularly not only in North Carolina, but particularly in a rural area, because quite frankly, to find somebody with that kind of expertise, you've got to go to a huge urban area to do that. But right here in Sampson County, in eastern North Carolina, folks have access to an orthopedic surgeon and also a sports medicine specialist. Right. Tell us about how you came about that and how important that is to your practice.
Well, I'll tell you, it came from a couple of different things, but number one, I've always had something on the horizon to work towards or look for. That's kind of the apple that dangles in front of me that motivates me to do something more. And I'm not sure what is next on the horizon, but I'll find something and I'll work for that too. But in terms of the sports medicine certification, most people's experience with orthopedic surgeons, if they've gone to an urban area like Raleigh or someplace, each practice has orthopedic doctors that specialize in certain areas of the body. And one of the more common ones is sports medicine. And the American Academy of Orthopedic Surgeons recognized that there were team physicians all over the country on high school sidelines and college sidelines and professional sidelines that really had no certification. And although they may be experts in treating the musculoskeletal injuries like the broken bones, the sprains and strains, they really weren't that educated about treating some of the other sports medicine problems like heat exhaustion, heat stroke, malnutrition or poor nutrition, eating disorders, bulimia, anorexia, things like that. There's a lot of things that go into sports medicine, including things like chronic diseases such as asthma and diabetics that are playing football, asthmatics that are playing sports, soccer and basketball, and I think the American Academy of Orthopedic Surgeons was really on target when they said we need to get some education so that we can really increase the level of care for these athletes. And so they started a program that was also offered to practicing orthopedic surgeons, and it was a 3-year program. And I jumped on board the first chance I got and went through a 3-year process of education and then also submitting procedures that I was doing, a case log, a case report. And once that case log met satisfactory requirements, then I was able to take a test. And the same test that's given to graduates of residency programs now, but I was able to obtain that even after my residency training. And so I was very proud of that. And like you said earlier, when I went through the process a couple of years ago, only 1,500 people had completed the course, and now it's about 2,500. And so I will tell you, it's pretty rare in Eastern North Carolina to have a orthopedic surgeon who's also board certified in sports medicine. So I'm very proud of that.
One of the things I think is interesting to mention too, and pretty modest, but I want to mention this. You do a lot of donation of time and volunteer work and helping folks out, whether it's coaches or school athletes, and you're out there on the line. Sometimes folks don't know it, so I think it's important that we mention that, and whether it's at Harrell's or whether it's one of the public schools here in the county. And I think you've had communication with some of the school leaders here and trying to expand that.
Well, I'll tell you, just in the last month, over the summer, everyone's concerned. You may have children or grandchildren or nieces and nephews that are playing sports. And if you play sports in Sampson County or in the state of North Carolina, you've got to have a pre-participation physical before you can play. And that's often cumbersome to get and costly. You've either got to make an appointment with your primary care provider and get seen for a physical exam with its required co-pays, et cetera, or you've got to go to an urgent care or quick med or someplace and get the form completed. We have actually gone to the schools just this summer. I've been to Hopton High School, Lakewood High School, and have been to Union High School twice, and to Harrell's Christian Academy. And we've done physicals, and we've charged the children $10, and then we've taken that money and given it back to the school. And so if you go and do 60 or 70 physicals on these kids and you raise $700 for the athletic department at Lakewood High School, and you give that check to that athletic director, they're happy to get that, because in today's economy, there's not a lot of money for extra basketballs and field maintenance and things like that. So that's something we've been doing for the last few years, and I've enjoyed that. And coming up, we're going to help sponsor the Pigskin Jamboree, the hospitality tent there. We spoke with Colonel Macon earlier today. So that's something we'll do.
We're going to take a break, and we're going to come back and talk about some of the specific things you do, and particularly as it relates to knees. Ladies and gentlemen, stay with us. We'll be back with Dr. Alex Huff talking about surgery and surgical procedures as it relates to you possibly. Ladies and gentlemen, welcome back. If you're watching us on Star Vision Channel 16 TV, Star Vision Cable Channel 16. If you're listening to us, WCLN 1170 radio, covering about 8 or 10 counties here in southeastern North Carolina. We appreciate you tuning in. Also, would like to tell you that the subject today is about, particularly about healthcare, focusing on some of those things that may or may not be affecting you. And a lot of people, as they get older, find that they have to have replacements in certain areas. They have things that hurt they didn't even know they had. And we've got Dr. Alex Huff with us today, orthopedic surgeon and sports medicine specialist. Dr. Huff, I want to thank you for taking time to be here. We were talking about, as we went on break, sports medicine in the sense of a lot of things you're doing at the high schools and those kinds of things. And I just want folks to know that when you go out and to do these things at high schools and you contribute your time, you're not only contributing your time, but oftentimes you go with a staff of people as well. So it's it's interesting. You not only talk about it, but you put your folks in action, and they go out and actually look very closely at these athletes before they actually get on the field.
Right. We usually take a staff of anywhere from 4 to 6 people, depending on how many athletes we think are coming in. But a lot of times we'll go down to the schools and we'll see anywhere from 60 to 80 or even more in an afternoon. And yes, it is costly. I'll admit that. You know, and I rethink it time and time again. But I do know that a lot of these kids are underprivileged. A lot of these kids don't have access or don't have easy transportation, you know, and you'd hate to think that a kid's not going to participate just because he can't get his form completed. But we're providing a service, and we also find problems. You know, we identify asthmatics, and we identify kids with heart murmurs and things like that. So I think we're providing a good service, and I'd like to think it comes back to me. I mean, I think if surely some of these kids, hopefully not, but they're going to sprain something or break something or hurt something. And I think when those things happen, hopefully their parents will think about Dr. Huff.
Absolutely. Absolutely. I want to talk about some of the things that you kind of focus on here in the area. And I know one of those things that you do and do well and have done for years is this whole issue with knees and working with folks as a portion of that knee just does not function correctly. And we see it, this is something that's interesting to me, and you can respond to this. We see a lot of ads on TV oftentimes about you need to ask your doctor about so-and-so, and I'm literally amazed at that because obviously when I look at it, I get a sound bite and a picture, and it sounds good and it looks good. Do you get a lot of folks come in your office saying, oh, I want that kind of knee, or I want this kind of knee, or my knee hurts, and before you even get into it, they're telling you about a commercial, that's all?
Absolutely. And you have to remember that is a commercial, and it's commercially driven. It's driven for economic gain by the manufacturer or the people involved with it. But I will tell you, the science of knee replacement has changed dramatically. I would equate it to the evolution of flight. When you think about in 1903, Wilbur and Orville flying a biplane canvas wooden structure, and then 70 years later, we're going to the moon. So knee replacement has evolved from the 60s and early 70s to today in much the same way. It used to be the very first knee replacements were taking the end of the thigh bone and cutting the bone off and covering it with the bladder of a pig. Okay, so that's something else that I bet the hog farmers in eastern North Carolina didn't know the hog was used for.
Wow.
But covering the end of the bones with pig bladder because your body could accept it and it would not reject. But obviously those did not function very well. It eventually led to folks in England figuring out that you could use metal safely in the body, and metal and plastic knee replacements. And so the total knee replacement as we know it today really became fairly effective in the late 70s, early 80s. And then it really didn't change that much through the 90s. The bearing surfaces changed so that they didn't wear out as fast. They lasted a little longer. We went from just plain stainless steel to some fancy alloys and using titanium in the knee replacements so that they had better characteristics, more similar to natural bone. But largely the procedure itself, the incision, the cuts, and all those kinds of things, hasn't changed that much until recently. And most recently, there's been a push towards or some interest in partial knee replacements. And I'll tell you, I was involved with the first series of those back around 2000. There was a first generation partial knee replacement, and I did about a dozen or so here in Sampson County, and kind of got away from them because the track record just wasn't panning out. They weren't lasting like they were supposed to last. But now, again, some English surgeons in Europe have been doing a special knee replacement called the Oxford knee replacement. Anyone with a computer can Google Oxford, England, or Oxford knee replacement and get some information about it. But it's been used in over 400,000 around the world, and it's been used in about 30,000 in the United States. And we've done the first two of those here at Sampson Regional Medical Center just in the last month.
And you've got some examples you're going to show. Let's look at the knee replacement, the full knee replacement first.
First,
and
this is
for our radio folks. We'll try to talk you through it so you can kind of see a visual. But what we're looking at here is where the knee joins.
So this would be the end of the thigh bone and the top of the shin bone, or the knee, where it comes together. And traditionally, a knee replacement would shape the end of the femur bone or the end of the thigh bone so that it would accept a metal covering, and then likewise shape the top of the shin bone so that it would accept a metal and plastic liner. And the plastic liner articulates with or runs against the metal. And if you notice, this basically resects or takes away the entire end of the thigh bone, the top of the shin bone, and resurfaces it. And it works great. It's tried and true. It's the gold standard, but some people don't need all of that.
If you do one of these knee replacements on one leg, does it offset your step and balance if you just do one, or do you need to do two, or how do you look at that?
It depends on the individual patient. Sometimes both need to be done, but more often than not, only one needs to be done. But we take all that into account. But bottom line, this is a more invasive procedure, and although it works great, it's the gold standard, tried and true, and it works well. Sometimes it's not absolutely necessary.
But with that procedure, the leg actually is completely in two halves. I mean, you just
Correct.
pull it apart and put it back together.
Correct. And this is an example of the Oxford partial knee replacement. And if you notice, there's less metal and plastic here. But basically, we're covering only the affected side of the bone, and 85% of the population the inside part of the knee wears out way faster, much more faster than the outside part of the knee. And most people that come to see me have a normal outside of the knee and are fairly normal under the kneecap, but the inside of the knee is where their knee is worn out. And so this Oxford knee replacement will cover only the affected side through a much smaller incision, so a shorter stay. And the beauty of this is that there's a mobile bearing, a plastic mobile bearing that can be inserted, and these come in various sizes, and it can be inserted and it actually moves with the knee. And I don't know if our folks at home can appreciate that, but
we're going to try to give you a close-up for our radio listeners. Basically what we're looking at is, previous to the other shot we're seeing now, is half of the knee as opposed to the entire knee, and the joint replacement is looks like maybe 30-40% of what the entire previous one was. So this is a huge advancement.
Right, and from all of the preliminary data that's coming up, there's 10-year data from around the world, and there's several year data from large replacement centers here in the United States, in New York, Chicago, and some other places, Indiana. But from the early data, it looks like this is going to have the same longevity, if not even more, than a total knee replacement. So much so that the company that manufactures these and that is distributing them in the United States now is actually putting a guarantee on them. It's the only knee replacement that's ever been made that has a guarantee. Now there's some caveats to that guarantee, but basically from my understanding and talking with the distributor is that if that needs to be revised to a total knee replacement, the cost is subtracted from the second surgery.
So that's a financial advantage, especially to folks now, and we'll talk about a little later in the show some of the insurance issues, but that'd be a great advantage to folks now as they look at cost, and especially out-of-pocket expenses.
Yeah, it's going to be like buying a set of tires that has a certain guarantee on it, and if it doesn't meet the requirements, then it's got a prorated discount on the next set or whatever, something like that. But anyway, I think that's interesting that it's the first one that's ever been made that has some type of a guarantee like that.
And Dr. Huff, one of the things I think is important too is that one of the very few that's been done here in Eastern North Carolina, you've been involved in that.
Yes, we've done 2 here at Sampson Regional Medical Center, and based on the data from the distributor that distributes all of North Carolina, the information is that only a handful have been done in Goldsboro and Wilmington, and a few more have been done in Fayetteville. But I'm proud to say that now I've completed the most advanced training course for this particular procedure and feel very comfortable, very confident doing these here at Sampson Regional. Our 2 patients that we've done have had a very half the length of stay in the hospital, and have been walking when they go home and are doing well.
The knee replacements that you've seen in most of the patients, and we'll look at statistics for a moment, is the majority of those patients because of an older age and wearing of the knee, or do you see folks that are younger that's been involved in sports that actually needs knee replacement?
I mean, both. There's actually what's termed a bimodal distribution pattern. There are people that are in their 40s whose knees are worn out that have either had trauma or some type of an injury to the knee that's led to an acceleration of the arthritis in the knee. And then there's people that are in their 70s and 80s who have just worn their knees out. And I've told people before, and in fact I've mentioned it on this program, but I think that people's genetic quality of their articular cartilage is largely inherited. And just like your teeth, some people, we all know people that we go to church with or friends or relatives with, they're 90 years old, they got every tooth in their mouth, and they may or not even brush them. And then there's other people that are meticulous about going to the dentist and taking care of their teeth, and they still lose their teeth at a younger age. So I think that the articular cartilage in your knee and in your hips and in your shoulders is similar. Some people's just last longer than others for whatever reason.
And you have some folks that have a certain color of teeth, and it's like they're brilliant white, and other people just can't get there.
Right, exactly. So it's largely inherited.
Well, genetics, I think, has a lot to play to do with a lot of things we do. What I'd like to do when we come back from this break is talk further about some of the other procedures you do along with the knee replacements. And I think here in Clinton, one of the key things is reminding folks that Huff Orthopedics is right in Clinton, and give us that telephone number so we can get in a few times.
It is 596-5633 or 596-KNEE, K-N-E-E.
We're going to be back in a moment. We're talking with Dr. Alex Huff. We're talking about replacements in case you need some. a doctor if you need one of the best in North Carolina, in the eastern part of North Carolina, in the United States. Dr. Alex Huff. We'll be back in a moment with We Should Know. Ladies and gentlemen, welcome back. We're having a lively discussion today with Dr. Alex Huff. Want to thank all those folks on the radio that mentions this show each and every week. The Boogie Shoes Radio Network with Robert Stroud on Saturdays. Robert's always kind enough to mention our show and what's coming up on We Should Know. We want to mention him. Also, we'd like to mention that morning show that a lot of folks listen to with the L Man and Nolan Z. And, of course, who can forget Grandpa is on there as well. We'll also mention Wayne Weeks, the Southern Gospel Hour on the radio. Wayne mentions us quite frequently. Don Smith with over 50 years of radio experience. He has something called the Country Store. If you really want to get a flavor for Sampson County and eastern North Carolina, just listen to the Country Store and you'll find out what's going on. And again, Tommy the Fly has some good old-time music, I call it sometimes, when you get back into the 60s and 70s. He plays that for you in the afternoon. A lot of things happening around in the area. Dr. Huff, thank you again for taking time to be here. And I'm always so appreciative of guys like you to take a few minutes and come in and sit down and talk to folks, because I know a little bit about your schedule, and it don't take a person long to just realize you've got a stacked schedule, and to get you out of an emergency room or an operating room or to a clinic setting, if folks see you out there, I just like to ask them to just kind of slap you on the back and say, appreciate what you're doing. So you're a great advantage to the community.
That. Thank you.
We've talked about a number of things today, and we've looked at some of the knee replacements you do, but let's talk about the body itself and some of the upper extremities that you deal with and that you can deal with on a regular basis, because I get the sense that there may be some folks out there that is in pain. They may be hurting. They may think, well, I wish this pulled muscle would go away, and it may not have anything to do with that. So let's start out, and I'm just going to let you start out with the upper extremities and kind of give us an overall of some of the things that you can work with.
Okay, I'll be glad to. I'll talk about some of the more common things that we do in the upper extremity, and then maybe we'll talk about the lower extremity also. And I'll tell you from the get-go, if I don't do it every month, I don't do it. I'm fortunate to I'm a social person. I've got friends in every community around us, and depending on what part of the county you live in, I can get you to someone else if I think they can do a better job than we can here, and I'll readily admit that. I'm not an expert in everything. But I do a lot of things, and the things that I do often I think that I do well, and we do well with the help of my staff at Sampson Regional. We'll start with the shoulder. I do shoulder arthroscopy, and I was telling you earlier, we did the first shoulder arthroscopy here in Sampson County, back in 1998. Mm-hmm. And so a lot of the things have evolved in the shoulder, from big open incisions, fully exposing the joint, to arthroscopy with just small incisions or to lesser incisions on the top of the shoulder. But we remove bone spurs. We take care of bursitis. We take care of arthritis in the AC joint or the collarbone joint. And then we repair rotator cuffs. And I do those every week, sometimes several a week. And that's usually done either as an outpatient or with an overnight stay. A
rotator cuff, give us an example. I hear folks periodically say, I had to have my rotator cuff done. Right. It seemed like 2 or 3 years ago I was talking with a friend of mine who was Highway Patrol, and he had his rotator. He said prior to that, I was in unbearable pain. Right. He said now everything is wonderful. So tell us what that is and why it's so painful.
It's a great operation, but it's painful because it's so close to your core, so close to your head, and things that are closer to your head hurt more, in my opinion. So I think that your shoulder hurts more than your toe would. But anyway, the rotator cuff is a confluence of muscles, or a group of 4 different muscles that help to position your shoulder so that your larger muscles, the deltoid, the biceps, and the triceps, can help you do the work. If you think about, if you've ever seen a building being built, a lot of times there's a large, some type of an erector, and it'll have a huge motor that really lifts the heavy beams and things, but it's got a small motor that helps position that thing so that it can work more efficiently. And that's what your rotator cuff does. But without the rotator cuff, the motion of your shoulder is just not efficient, and the ball rides against the bone, rides high or rides low, and is very painful. And so usually through an incision in the front of the shoulder, I can repair the rotator cuff back down to the bone, and that heals over the course of a few weeks. And I've got many patients that I've fixed one shoulder, then they come back and get the other shoulder fixed, a few years later, because they're so pleased with the first one. But that's the rotator cuff. People tear them traumatically with you think of it as a baseball pitcher throwing, but more commonly what I see is a weekend warrior playing a church softball game, or a middle-aged person who's lifting something too heavy, not expecting it, lifting a suitcase or putting something in the trunk of their car. But if you get to where you can't get a gallon of milk out of the fridge and you're having trouble getting dressed and you can't sleep on that shoulder, you might want to call and come in and see me, and we'll talk about it. I also do a lot of carpal tunnel surgery. That's one of the more common things that I do. And this environment that we have around us with all of the meat processing plants, people using their hands a lot of repetitive motion type things. I do an awful lot of carpal tunnel syndrome surgery. I do injuries to the hand, broken bones. People are constantly finding ways to get their hands caught in machinery. I did that yesterday. I see that just about on a daily basis. Someone who has mashed their finger, hooking a trailer to a truck, or gotten a piece of machinery, farm equipment, or cut themselves at work. I do an awful lot of that, tendon repairs and things like that. I do arthritis surgery on the base of the thumb. A lot of people have painful, prominent bone spurs around the hand, and we can do smaller joint replacement type procedures for that. That's the upper extremity. Then in the lower extremity, arthroscopy around the knee through just 2 small poke holes. We can take care of a lot of things like torn cartilage, loose fragments of bone, cartilage, things like that.
When you do things like that, is that an effort of extending the time that you might have to come in and do a knee replacement? I mean, is there a particular age, if you can extend that you will put it off longer so you don't have to come back? Is that a...
Yes. What I try to do is we base that on the x-rays. And a lot of people wonder why sometimes they've already had x-rays at their primary care physician's office, but they come into my office and I want a new set of x-rays, because I do them standing. I want standing film so I can see what those bones look like when the pressure's on them. And if people have bone-on-bone arthritis, then at that point it's really injections or types of replacements. But if there's still some joint space, still some tread on the tire, I call it, then arthroscopy is usually very helpful and can help forestall and delay knee replacement. We also do operations around the foot and ankle. We do all the bunion surgery, hammer toe surgery. I think a lot of people don't really realize that, because I see an awful lot of people that go out of town for that, which is okay. People need to go where they're more comfortable, but I do want people to know that we do all of those. We do all the bunion surgery, hammer toe surgery. We take care of plantar fasciitis or heel spurs, things like that. And of course, all the broken bones. People are constantly finding ways to fall off of things and trip and fall and break their bones. And I treated your mother, with a broken bone recently.
Absolutely.
So anyway, so we do all those kinds of things.
And I think the interesting thing is when you talk about that, you think about age, and it's like with my mother, you think about age with her and hip replacement. And then I see people that are much younger and they've run into similar situations. So I think it gets back to one of the things you mentioned a while ago. There's a certain amount of genetics that's involved in the stability and the makeup of that bone structure itself.
Absolutely. It's just like a lot of other diseases, whether it's hypertension, high blood pressure tends to be in more different groups of people, and high cholesterol and heart disease. A lot of these things have modifiable risk factors like smoking and these other kinds of things that you can change that. And from a musculoskeletal standpoint, you can maintain healthy joints by stretching, walking, exercising, running. These kinds of things are good for you, for your skeletal system overall. But we can only modify them to a certain extent. Genetics plays a huge role.
Well, I think it's important that we look at some of those things, because folks that are listening to this show, my big concern is that they may be suffering with some pain, but they don't have to.
Right.
And do you get a lot of folks that come to you through the emergency room, or is a lot of your folks just patients that sign up and say, I need to see Dr. Huff?
I probably get a third from the ER and a third from my primary care physician friends in the community, and then a third people just call to come in. And I think people do need to know that you can call and make an appointment, and I'll be glad to see you. We do an awful lot of primary musculoskeletal care. When I say that, I mean we do an awful lot of non-operative care. We do injections. I know I wanted to mention that we do the hyaluronate injections. Hyaluronate is a lot of times people know around here is the rooster comb shots, but there is a synthetic liquid that is very similar to joint fluid that has been manufactured that can be injected into the knee that will help cushion against the bone-on-bone arthritis and help restore normal viscosity to the joint fluid. And a lot of times people I hear will go out of town for things like that, and they can if they choose to, but they don't have to. I want them to know that we have that readily available here, and I've been using those materials since 1998.
It's a lot of these procedures, some that you can do right in your office,
Yes.
at your office, rather than going to the hospital.
Yes, absolutely.
And I think that kind of helps people a little bit, because if they go, they may be able to get that procedure done, leave, go on home, and it's over.
Exactly.
Because
Right.
one of the things I think with healthcare, and we'll talk about that hopefully in a few minutes, with healthcare now, the length of time is becoming very important, and how much attention you have to pay to it.
Absolutely.
So as we look forward to this last segment, I want to kind of focus on some of these other issues and ask folks to tune in as we move forward. But the dynamic of what we're seeing today with all the surgeries you've done and all the patients you've seen, if there's a question and it relates to movement, if it relates to any kind of issue about bone, they can call you at what number?
596-5633 or 596-KNEE.
Okay, and when we come back, we're going to talk about some other issues. So one of the things I wanted to kind of go to break is a quick explanation, if we got a second to do this, the difference between a fracture and a break. A lot of people say, oh, I only had a fracture, as if it were not a break.
I'm glad you asked me that, because I'll ask you, do you drive a car or an automobile? If you drive an automobile, you have a fracture. If you drive a car, it's broken. So basically, it's the same word. It's synonymous. It means exactly the same thing. It's just a difference in the term. And
I hear that all the time, and I'm so glad you put it in that context. The reality is it's the same thing. So,
yes.
So no matter what happens, if you come in and somebody says, well, look, you've got a fracture, it may sound better,
right,
but your bone's broke.
Exactly.
And sometimes it's the same procedure you got to go through to fix that.
It all depends on how displaced the bone fragments are.
The mobility issue.
Right. Yes.
Dr. Huff will be back with us in a moment. Ladies and gentlemen, you're watching WCLN, radio, TV, all together, one show. We simulcast together. Star Vision TV, Star Vision Cable. It is Channel 16. We invite you, if you missed the show today, replay 7 p.m. Tuesday, Wednesday, and Thursday, uploaded to YouTube now. So worldwide, you can see us and hear us. We'll be back in a moment with Dr. Huff. Ladies and gentlemen, welcome back. I want to thank you for watching us today, for listening to us on WCLN Radio, Star Vision TV. Been an interesting discussion. Dr. Alex Huff has been with us, orthopedic surgeon right here in Clinton, sports medicine, located right across from the hospital. Dr. Huff's sponsor of this show. Dr. Huff, thank you for being a sponsor of our show for a number of years now. Actually, since we've been on the air, you've been stood with us through everything we've brought on. So
glad to do it.
It's interesting when you look at these things, and time goes so fast. So we've got a couple of things I want to cover, but I can't get away without talking about osteoarthritis, arthritis in general, rheumatoid. There's a lot of misconceptions, almost like your explanation of a fracture versus a break, but there are distinct differences there. Tell us about that.
There are. Very, very briefly, arthritis in its simplest terms is inflammation of the joint, and there are several forms of arthritis. The most common is osteoarthritis, and that's what most people suffer from that I see. Also common but less common is rheumatoid arthritis, and a lot of people have trouble distinguishing between the two. But basically, osteoarthritis is what's termed wear and tear arthritis, and it does cause inflammation of the joints and severe pain, and is the most common cause for needing things like knee replacements and hip replacements. It's treated with injections and medications, and then commonly replacement surgery when the bone becomes when the cartilage is completely eroded and it's bone on bone. Rheumatoid arthritis, by contrast, is more of a systemic disease with positive blood tests. That's largely treated by your primary care physician, and usually in conjunction with a rheumatologist, is treated with some of these disease-modulating drugs like Remicade and methotrexate and these types of medicines that you might see commercials for. It is it more affects some of the smaller joints, and you'll see people with crippled hands, crippled fingers from rheumatoid arthritis. But it's also a common cause of needing knee and hip replacements. One of the more common confusing things that I run into is people have a question as whether they have osteoarthritis or osteoporosis, and what's the difference between the two. Osteoarthritis is erosion of the cartilage where you have inflammation of the joint, and it leads to bone-on-bone inflammatory pain, and that's what you talked about, wear and tear changes. Osteoporosis is a decrease in the density of the bone, so the quality of the bone, its weight-bearing characteristics, and its strength is affected. And so people with osteoporosis are usually monitored by their primary care physician with a bone density test to check the density of the bone, and then oftentimes are prescribed medications to improve the density, not just calcium and vitamin D, but medicines that will improve the density of the bone. And without those medications, those people are at higher risk for breaking bones. It is staggering the number of elderly women with osteoporosis that will break bones in their back, compression fractures, break their hips, and break their wrists. And those are the three most common. But that's usually followed and treated by the primary care physician until a break occurs, and that's when I get involved and see the patients. But osteoporosis is soft bones, weak bones that can be treated medically. Osteoarthritis is inflamed joints and pain that's often treated with injections or surgery.
And if someone has a question or they're not sure about that, obviously they can call you, and your number, again, I'll let you go ahead and give that number again.
596-5633, which is 596-KNEE, K-N-E-E.
Call and you can evaluate and determine what's going on.
Yes.
A lot of other things I want to talk about today, but I want to try to get this in because we're kind of in our last segment here. The whole insurance industry is dramatically changing. It's impacting doctors that general practitioners. It's impacting specialists like yourself. What are some of the things that we need to know, and how is it affecting what you're doing in this community and your ability to continue to do some of the things? Because cost is becoming apparent and important, and has been, but really now you have almost like the quality police out there that are affecting things on quality that is not necessarily the type job you do.
Exactly. I'm telling you, it's so much to go into right now, but briefly I'll say that things are changing. We're in the middle of change, and I think it's going to be a couple of years before we see how, before there's some stability to the system. But there are some things that I think just the general consumers, need to hear, and one is that costs are too high, and money is scarce, and so resources are going to be rationed. The types of providers that we see and our ability to see specialists and medical doctors as opposed to other healthcare personnel such as nurses and nurse practitioners and physician assistants, more of the role of treating patients will be delegated and assumed by other ancillary staff. And so I get it all the time. People want to see Dr. Huff, people want to see the doctor. But unfortunately, our system is steering us away from that. And then we talked about quality, and the president will get on television, and legislators will get on television and talk about how we're going to change the way the physicians are paid. Instead of paying them on volume or on the number of patients or procedures that they do or see, we're going to pay them on quality. And really what I want you to understand is that cost is how they equate quality, okay? And so physicians that sit down and spend a lot of time with you, physicians that order tests and order complex tests like MRI scans, CAT scans, ultrasound tests, and things like this because you're concerned about them. I'd like to think if I go to the doctor and I'm concerned about a pain I have in my abdomen, I'd like to think that doctor can order a CAT scan if I feel like I need one or if he feels like I need one. But what's happening is that the insurers are measuring the number of tests that doctors order, and those that offer fewer tests are seen as having better quality, when in fact that may or may not be the case. And so those types, so now the incentive is to not order tests, not order any expensive technology, which may make a more accurate diagnosis, but it comes at a cost. And the insurance companies are measuring us by the amount of, by how much we cost them, just like consumers are measured by, just like insurance companies measure the consumers by how much they cost them. They may eliminate you from a pool or from or deny you insurance because they think that you're going to cost too much money. They're doing the same things to the physicians now, which is unfortunate.
And I had one doctor explain to me, it's, instead of leveling up, it's a leveling down process. So you're actually getting less, and docs like you that are there, that have the background, expertise, and credentials to say, I want to look closer, is being checked off on by someone that works for a business, i.e. an insurance company, that is looking after the bottom line of the insurance company, that is measuring quality on a numerical dollar scale rather than on what they actually need.
These peer reviews, I call them, if you come into me and you've got a sore shoulder and I suspect you've got a torn rotator cuff, I may want to order an MRI scan to determine the best way to treat it, how to fix it. To do that, I may have to call a 1-800 number and get somebody on the other end of the phone who is not likely an orthopedic surgeon. And I'd like to say if they were orthopedic surgeons, I don't know why they're not practicing, because I think they could probably do better in the private sector working than they could answering the telephone and denying MRI scans for patients.
Absolutely.
But it may not even be an orthopedic surgeon, and they're looking at an algorithm and determining whether or not you can have an MRI scan, despite the fact that they've deducted your premium electronically from your checking account every month for the last 20 years. They are very hesitant to allow us to spend any of that money. And that salary for that reviewer is coming out of your premium, and he's getting most likely incentivized to deny you spending or me spending, as a physician.
These are the real issues that folks need to be aware of, because, and again, I get back to my point that when folks see you and other doctors, especially specialists out there, that are willing to live in a rural community like Eastern North Carolina, any one of the communities here in Eastern North Carolina, we owe a lot of gratitude to folks that's willing to do that, and especially as we go forward with this unbelievable health care bill, a lot of folks really is just unfolding before us. We're going to have less and less opportunity to bring people here.
Right. I haven't read War and Peace, but I know that this Healthcare Portability Act, Obamacare as we call it, is twice as long as War and Peace. I doubt it's been read word for word by anyone that's acted on it in the legislature at this point. I've read summaries and I've tried to get a grasp of it and stuff, but I don't think that any of us really understand the ramifications of it. But suffice it to say that more people are going to be insured, and that's a good thing. I think they're going to raise the Medicaid rates to 133% of the poverty level, so I think there'll be some indigent people that really need care that will be able to get some care. But I would argue on the other side that these people still get care now by coming to the emergency department and calling me, and I treat them. But anyway, we're going to be able to insure more people, but we're not ready for it. There's not enough physicians, and so therefore they're going to be absorbed by the other ancillary care providers, nurse practitioners and physician assistants, who are great people and great providers, but they don't have the same level of training as medical doctors. It's going to come at a cost, and I'll leave it at that, but you get what you pay for, and that's how healthcare is going. I think it's interesting, in some places like Chicago and New York, I've got friends that are orthopedic surgeons, they don't take Medicare or Medicaid. I think that's unusual. Some of them don't even accept insurance. The demand for their services is so high that although they'll help you file your own private insurance, they expect payment in full, just like if you were going to buy a car or something when you get a joint replacement. Now, we'll never do that in Sampson County. I enjoy what I do. I love where I live. I love the people I deal with. And I'll continue to accept all kinds of patients, and Medicare and Medicaid are how I make my living. And so I'll find a way to do that. But things are changing in healthcare.
And I think the unfortunate thing is to retain specialists like yourself and the best and brightest in the field of medicine is becoming very cloudy as to whether those folks are going to look at that as what the future is. So again, I want to thank you for being here. Give you a couple of seconds. Anything you need to say before we close out?
Well, first I'll say thank you so much to the citizens of Sampson County, and when I say that, I mean Sampson County, Duplin County, Bladen County, Johnson County, Harnett County, Pender County, Wayne County. I've got patients that I see every week from Richlands and Beulahville to Elizabethtown to Spivey's Corner and Benson area, all the way down to Wallace, and I appreciate the opportunity to be able to practice my craft and my brand of medicine here in Sampson County. If you have problems, call us. We can get you in quickly. Sometimes there's a wait, but we can get you in quick.
Dr. Alex Huff. Alex, thank you for being here.
Always
a pleasure.
All right.
Ladies and gentlemen, you've been listening to Dr. Alex Huff, Huff Orthopedics and Sports Medicine in Clinton. Stay with us for next week. We'll see you again on the radio.
Thank you for tuning in to this week's episode of We Should Know with host J.W. Simmons. If you have a question or comment regarding this or any episode, please send your email questions and or comments to jwsimmonsedu@gmail.com. And remember to tune in every Tuesday afternoon beginning at 2:30 for another informative episode of We Should Know.